The following episode is brought to you by the American Urological Association. This episode features content from the AUA 2025 meeting in Las Vegas. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. This educational activity is supported by independent educational grants from Astellas, Janssen Biotech Inc., administered by Janssen Scientific Affairs LLC, Lantheus Medical Imaging, Novartis Pharmaceuticals Corporation, and Pfizer Inc.
Well, it's great to see everyone this afternoon. I'm excited to welcome you all to this course, implementing the AUA guidelines for early detection of prostate cancer, maximizing benefits and minimizing harm. So welcome all of you in the room in person, as well as a number of people who are listening in online. So those are the announcements. So first, just a quick introduction of the course faculty. I'm Simple Salami, urologic oncologist at the University of Michigan. I co-direct this course with Dr. Sigrid Carlson, who is an associate attending epidemiologist at Memorial Sloan Kettering. We have Dr. Scott Egner, professor of urology at the University of Chicago. Dr. Carol Woods, associate professor of urology at the Montefiore Medical Center, Albert Einstein College of Medicine, and Dr. Daniel Barocas, who is a professor of urology at the Vanderbilt University Medical Center. Hopefully you had the opportunity to review our disclosures, but these are the relevant disclosures, and each of the speakers will highlight what is relevant as well at the beginning of their talk. Also, I hope that you took the time to look at the learning objectives for this course, but they're listed here. And essentially what we're going to do today is cover how to utilize PSA isoforms or derivatives, how to use biomarkers, how to use MRI in early detection of prostate cancer. And then we'll talk about biopsy strategies as well that you can implement in your practice. And this is the outline, a brief outline that we're going to follow. And we will also be making references to the handout that you picked up on your way in, figures 1, 2, 3, the flow charts that are included in the AUA guidelines for your reference. At this time, we'll begin our very first talk on prostate cancer screening, and that will be Dr. Egner.
Thank you all for coming, and I will just put in a plug. Please give critical feedback at the end. We pay attention to it every year, and the sole purpose of doing this is to try to make it as practical and useful as possible for the audience. So I try to be exhaustive in these are disclosures from many years ago, but I still think it's important for you to know, and many of these aren't even discussed. I still err on the side of putting them up there, leaving them up there for a little bit so that you know. 0 of these are relevant for the talk, but for full disclosure, I do put them up there. I have a lot to go through, and I have 10 minutes to do it. I'm going to go relatively quickly and not go super deep, but I hope there's a lot of nuggets in there that you either already know, and obviously the goal is stuff you don't know that might be practical. The way I see it is thoughtful prostate cancer screening saves a lot of lives, up to 50% in the US. We have data. We still have a massive problem with indiscriminate screening, and I think still somewhat of an epidemic of overdiagnosis and overtreatment. Practice patterns aren't optimized, and it can be extraordinarily expensive, the screening, diagnosis, management paradigm with prostate cancer. As I alluded to already, we're the maroon line there. Age-adjusted mortality from prostate cancer has gone down 53%. That's a huge win. We should celebrate that. There's obviously other elements to it. And the group that has benefited the most have been men of African ancestry. That's the green line there. They've had the greatest relative and absolute decrease in mortality, another thing to celebrate. But the elephant in the room is trying to minimize overdiagnosis and overtreatment. And that's the struggle in the clinic. You want to find the right people to screen and treat and get your hands off or never diagnose the people that are unlikely to benefit. If you look at the number needed to screen, to diagnose, save a life, and you put it in context of everything else we do that's commonly accepted in medicine, we're not doing so bad with our most optimistic models. Now, obviously, The big issue with prostate cancer is the prostate's at kind of ground zero, and the morbidity of treatment is a lot higher than a lot of other conditions that are on this table. I do think these are useful guideline, concordant things that you can integrate into your practice. Be fair when discussing the risks and benefits. We don't do a great job of it, and not every man needs to be screened, and some choose not to, or I discourage a lot of guys from being screening based on age or other health issues or a low PSA. You know this already. There's shared decision-making, tools available. There are sheets people hand out. There's videos. We could collectively do a way better job of informing people truly about the pros and cons of screening. This is old data, but probably still relevant today. If you ask people who are screened, their urologist or primary care physician tends to oversell the upside, minimize the downside, and we can do a better job of fairly explaining that to things. We still screen a lot of old, sick men. It is really low value. It's expensive. They get tortured unnecessarily. We can do better. This is the most recent data, and it's basically men screened within the last 2 years. You see in these age groups, it should be relatively rare, particularly these older age groups. If they're perfectly healthy, go for it. But most of these men don't need to be screened. It's a disservice to them. And this is just a way of showing whether they're healthy or unhealthy based on estimated mortality rates. The take-home summary is there's a lot of guys that are older, unlikely to live more than 5-10 years, that are still being screened, and we can do better. I like this data. I'm a numbers person, but you think of kind of average life expectancy of a US man. If they're made it to 65, the average guy makes it to 82. If they're healthier than the average person, their life expectancy is longer. Life expectancy on average doesn't drop below 10 years until they get to be 77 years old. So I do think it's very reasonable to loosely screen men in their upper 70s and 80s if they're way healthier than the average guy. But I also think there are 55-year-old men where it's silly to screen them because it's really unlikely they're going to make it more than 10 years. This was one of the questions. I think it's really important and the easiest, cheapest, freest thing to minimize unnecessary diagnosis. Always, always, always repeat a PSA. This is data that was published in JAMA over 20 years ago. The take-home summary is, without doing anything, just repeating the PSA 30 to 50% of the time, it's going to drop back down to a quote-unquote normal level, whatever you use as a threshold if you use thresholds. This is another way of looking at it. This is out of Sweden, 1,600 men, and they just repeated it 8 weeks later. I'll take you through this slide. The gray distribution is the change in PSA over 2 months. What we're trying to find are the people on the red line there. That's grade group 2 or higher. And the bottom line is, if the PSA has gone up, you repeat it 8 weeks later and it's at a similar level, it's probably real. That's your highest yield of finding grade group 2. If you repeat it and it goes down a lot, you have a lower yield. And if you repeat it and it goes up even higher, it's probably something, it's a higher likelihood of being non-cancer related, probably inflammatory or something that we don't understand. Don't ever give empiric antibiotics for an elevated PSA. This was done routinely. Nearly everyone I saw during residency got empiric 4 weeks of Cipro. Very first randomized trial I did as an attending was a 2-week randomized trial, Cipro versus nothing. I was lambasted for it that I didn't give enough antibiotics and it wasn't a good trial, so someone else did a trial for 6 weeks. It doesn't make a difference. If someone has an infection, treat it. Otherwise, there's absolutely no need to give them antibiotics. You're probably causing more harm than good. Baseline PSA is extraordinarily powerful. If you're gonna screen someone, there's a lot more signal to noise early on before BPH and prostatitis become confounders. Complicated slide, but extraordinarily powerful. 20,000 unscreened men. Gray is the distribution. These are young men. Almost all have quote unquote normal PSAs, but within that normal PSA range, in their late 40s, it predicts events decades down the road. So I think it's useful to remember median PSAs for men in their 40s and 50s and risk stratify screening, just like we do with colonoscopies. Not everyone should be screened every year or two, There are people you can encourage to get screened every 4 to 5 years, and others you want to keep a closer eye on. The most obvious thing I'm going to tell you, earlier screening for people at higher risk of developing the disease and from bad things happening from the disease. You know this already. Here are the increased risks. There are germline mutations, ancestral things. There are SNP scores or polygenic risk scores that are commercially available that can give you an estimate of the likelihood of them having bad cancers. A family history of prostate, breast, ovarian, or pancreatic cancer typically warrants germline testing. And even if they don't have a germline abnormality, if they have a family history of those things, I tend to be a little bit more aggressive with screening. PSA velocity makes a ton of sense, right? Your PSA has spiked up. And this is the cool thing about science. Sometimes what makes sense is true, and sometimes we get fooled. PSA velocity largely doesn't matter once you know everything else about that man, his history, and the PSA. This is some early data. The x-axis are higher PSA velocities, and the biopsy is more likely to show inflammation the higher that the PSA velocity is. And in some elegantly done modeling from huge screening trials and finasteride interventions, the take-home summary is once you know someone's age, total PSA, family history, DRE, you can't predict their likelihood of grade group 2 or higher any better if you have their PSA velocity. So don't biopsy people just on PSA velocity alone. And the reason for that is mostly because total PSA and PSA velocity co-associate so strongly. Free PSA. So if I'm getting screened and someone gives me this false choice of you can either get your free PSA or your total PSA, I'll take the free PSA every time. Because in models, free PSA is a lot stronger predictor of having a meaningful cancer than the total PSA. So every person I screen gets a free and total PSA. So they're the main drivers of a couple of the other secondary biomarkers. There's the 4K score, which you've probably heard of. I don't routinely recommend it. The main power of the 4K score is the 2K score. The free and total PSA, you get it really quickly. It's cheap and easy. You don't have to send it out. So that's what I do. Here's but one example of the power of free PSA. A 65-year-old man with a PSA of 4, no other worrisome features. So do you biopsy that guy or not? There's a variety of free PSAs you might get. And look at this. There can be up to a 6-fold difference in their likelihood of having a potentially meaningful cancer based on that free PSA. This is also the one time in clinic that I sometimes use these risk calculators. There's many of them out there. And I will sometimes plug and play and tell a guy there's an X% chance that we might find a grade group 2 or higher. Some of those might be clinically meaningful, some might not. And many guys say, I'll see you in 6 months or a year, and that's perfectly reasonable. Here's free PSA from the baseline free PSA level, 20 years median follow-up. Now the y-axis only goes from about 65% to 100%, but you can see based on your baseline free PSA, it very strongly predicts the likelihood of you being diagnosed with a potentially clinically significant cancer. The last few slides is also something that I use very regularly, and I just estimate it. I don't plug it into a calculator. No one commercializes it and markets it. It's extraordinarily powerful. The PSA density, it's mentioned a dozen times in the guidelines. Pay attention to this figure. It's complicated, but extraordinarily powerful. Again, distribution of PSA density is that gray distribution. You can't draw it any better on that red line. Remember, the red line is grade group 2 or higher, and PSA density is directly proportional to the likelihood of finding a potentially meaningful cancer. So I happen to do a lot of DREs in my clinic, and if you find a palpable abnormality, which can happen, it's relatively rare, but the main purpose and the most common one is I want to estimate the size of the prostate, and I just ballpark it. You kind of know if something's in the ballpark of 20, 40, 60, 100, or greater than 100, and I plug that into PSA density just in my mind as an idea of whether I'm worried about a guy or not. So that's my section, and I'll turn it over to my colleagues.
Okay, great. Thank you for that, Scott. So let's continue with the use of PSA, PSA isoforms, and risk calculators. These are my disclosures. So the PSA is still the first-line screening test. As of 2025, we don't have anything better to start with, so the good old PSA is what we recommend as a first screening test for prostate cancer. And we know from the trials in Sweden and in Europe, and I've been an investigator of these, this is the Göteborg 1 trial, where we did regular PSA testing every 2 years, men 50 to 70. We know that that reduces prostate cancer mortality, so screening works. And we see the same thing in the European ERSPC trial, and also in the PLCO trial. As you know, many men had a PSA test in both arms, but if you account for that, you can show that screening reduces mortality in both these trials. And this was the contamination in the control group. And even in the UK trial that was only one-time single PSA, you could also reduce prostate cancer mortality. Not as much, but still a strong signal there that screening basically works. And what about the interval? So it's very common here in the US to get an annual PSA test. Many men want that, and there's nothing wrong with that. And according to our guideline, we recommend every 2 to 4 years, because that was the intervals that was used in the European trial, and that it was a randomized trial. So that's why we have level 1 evidence for that interval. But that can definitely be adapted to risk factors and so on, and the man's preferences. And it's also important to notice that as the years go by, as you know, prostate cancer is a slow-growing disease, these numbers become more favorable. So the number needed to screen and the number needed to diagnose to prevent one death from prostate cancer become more and more favorable over time. And you can see how they become smaller and smaller. So this is an example from the ERSPC where you can see that now with 25 years of follow-up, the number needed to screen is down to 385, and number needed to diagnose 11. And this is, very low numbers. It's comparable to, for example, breast cancer screening, colorectal cancer screening. And we talked about the screening interval, and according to our guideline, we say that clinicians can personalize the rescreening interval, and the length can be adapted to a man's risk. And primarily what we mean by risk is a man's age and his PSA level. So for example, if somebody is between 45 and 70 and the PSA is less than 1, the interval can be prolonged. And we have many studies that shows that if a man is 60 and his PSA is less than 1, no further screening is needed, because the long-term risk of something bad happening to him, metastasis mortality, is so low that you can stop screening if you want to. And the same if somebody is 75 and has a PSA less than 3, that is also considered a low-risk group. What about DRE? I don't know how many of you still do DRE for screening in your practices? About 50-50? Yeah, this is exactly, how it is. And I don't think that's wrong. So we say that clinicians may use DRE based on preference. Some patients want it, and it's a very simple test. So it can definitely be done. But it actually has a very low value as a diagnostic test for screening, as you all know. And so, for example, here's a systematic review that shows that as a screening test, it's a not very sensitive test. And in the German ProBase trial, the detection rate of prostate cancer was very, very low, especially in young men between 45 and 50. So, but we definitely recommend DRE as part of a workup for an elevated PSA. And especially if the PSA is above 2, then we always recommend a DRE. And of course, if you're thinking about biopsy, then you always do the DRE before the biopsy. Risk calculators are also freely available online. This is an example from the PCPT risk calculator, and they can also help inform the decision to biopsy. And you can enter race, age, PSA level, family history, and so on. And which one to use? There are many different ones out there, and it's important to use one in the setting where you practice. So for example, here in the US, it might be the PCPT, or others in Europe, it could be the CHON or ERSPC, for example, which has been calibrated to the population of men. So who needs a biopsy? We have a long section on this later. Dr. Biomarkers will talk much more about this, Dr. Watts also. And so if the risk is low, clinicians can consider foregoing biopsy depending on various risk factors, and we will go into that more. So what about biomarkers? We heard about a few. We heard about the 2K score, which is one of the biomarkers. And these are recommended when the PSA is elevated as a reflex test and to reduce the number of biopsies and to keep the detection of significant disease and also reduce overdiagnosis. And as you know, there has been an explosion on the market recently. So every time we have this course, we have to add a new biomarker. And Dr. Salami will talk more about these. So there's many, many out there. And in our guidelines, you can read more about these. And you, as Dr. Salami mentioned, you will get these in your course package. But basically, you know, the gist is that if you look at systematic reviews of all these so-called liquid biomarkers, whether it's blood or urine, they really help reduce the number of unnecessary biopsies and reduces overdiagnosis. So that is the basic concepts of biomarkers. Okay.
All right, so I will be speaking about biomarkers and germline testing as well. These are my disclosures. They have no relevance to this part of the course. What I hope to do this afternoon is to review the rationale for using biomarkers for early detection of prostate cancer. We'll review the available biomarkers, blood-based, urine-based, as well as tissue-based biomarkers for early detection. And then we'll discuss the relevant guideline recommendations, and then we'll wrap up with germline genetic testing. So beginning with the first part, biomarkers for early detection. Essentially, a biomarker is any molecule, whether in blood or urine or tissue, that is a sign of a disease or an abnormal process, such as cancer. And as already mentioned, we have an embarrassment of riches when it comes to biomarkers in the management of patients with prostate cancer along the spectrum of disease. But of course, today we'll be focusing on early detection. Dr. Egner and Dr. Carlson already talked about PSA, and you hear about Stockholm 3 later in the course. So what I will talk about for blood-based biomarkers will be 5 as well as 4K score. So 5 is the blood-based test, assesses 3 different isoforms of PSAs, an FDA-approved test for patients with PSA between 4 and 10. And in this landmark study that was done in 2015, patients who have a PHI score of less than 25 were less likely to have cancer. They were less likely to have aggressive prostate cancer. And the performance of the PHI score, that is the combination of the 3 different components, outperformed any of the individual PSA isoform. And then the 4K score, as already alluded to, is a combination of 4 kallikreins, is a blood-based test as well, and a model encompassing the 4 different kallikreins with some clinical variables, including age, findings on DRE, as well as the presence of a prior negative biopsy was associated with clinically significant or high-grade prostate cancer. And a full model combining the 4 kallikreins with those clinical parameters did better than any model that leaves out any of the individual components. And what they reported in this study, I think, which is a challenge with most biomarkers, is that the performance of the test depends on the threshold or the cutoff at which you make the decision to act. For example, if you choose a threshold of greater than or equal to 9% to proceed with a prostate biopsy, you would avoid 43% of biopsies, and you only miss 2.4% of high-grade prostate cancer. Switching gears to urine-based tests, the first one I will discuss is my prostate score, or MPS. This is the first version of the test that combines urine PCA3 and TMPRSS2 with serum PSA. And this test has since been updated last year to include 18 targets, still including the initial 3 different components highlighted in red. But this time includes an additional 15 different targets, and the focus is to improve the detection of grade group 2 prostate cancer or higher. And with this test has a negative predictive value of 99%, and with a threshold of more than 10, you can avoid about 35 to 46 prostate biopsies. ExosDx combines three different components. This test does not require a DRE, and it is designed to detect grade group 2 prostate cancer or higher, and at a threshold of more than 15.6 to proceed with prostate biopsy, you can avoid 20% of negative biopsy. And the interesting thing about this is that at that particular threshold, you would miss grade group 2 prostate cancer to 2% of the time, and you would miss no grade group 3 or higher prostate cancer. The third one is SelectMDx. This combines DLX1 and HOXA6 in addition to clinical variables, and the goal is to improve the detection of grade group 2 prostate cancer. And the interesting finding here is an area under curve of 0.9. And then the last one is MRI Sentinel test. There are three different versions of the test. One version detects any prostate cancer, and then the second version detects clinically significant prostate cancer, meaning in addition to Gleason score or grade group, they use other factors such as PSA to determine clinical significance. And then the third version is designed to detect high-grade prostate cancer or grade group 2 or higher prostate cancer. And the area under curve is 0.98 to 0.99, but we're still awaiting a robust validation data set, because I think one of the unique findings in this particular cohort is the sensitivity and specificity that is more than 90%. And then the last test that I will talk about here is ConfirmMDx. This is a tissue-based test that assesses the methylation status of three different genes listed here. And the concept behind this test is the fact that when you have a cancer area, that the surrounding normal appearing or benign tissue may harbor molecular changes that could inform you that there's cancer that you have missed on the biopsy. And so in this study of about 500 patients who underwent initial and repeat biopsy conducted within 30 months, with initial biopsy showing no cancer and then the repeat biopsy showing cancer, they performed the ConfirmMDx test in all of the patients. And what they found was that all of the biopsies that showed grade group 2 or higher cancer on the repeat biopsy all had methylation changes. And this test was reported to have a negative predictive value of 90%, resulting in a decreased repeat biopsy rate of 64% if used. So this is just a summary of all of the different tests that we just talked about in the first three parts of the talk. And this test can be used most of them can be used in the initial or repeat biopsy setting. You saw this slide shown by Dr. Carlson, earlier. I think what we need is to be able to compare the performance of the biomarkers head to head, but we have very, very limited studies. And this is one study that I could find from like 10 years ago that compared 4K score and 5 score head-to-head in the same patient population, and they reported very, very similar performance profile, as you can see in the AUC comparisons for detecting any prostate cancer or high-grade prostate cancer. But then when you put all the different biomarkers into a table and look at their performance profile, you soon realize that their performance profile seems very, similar, both in the initial biopsy setting or the repeat biopsy setting. And in general, when you look at the data that is out there, both the development and validation data, I think we can say that these biomarkers tend to decrease the detection of prostate, tend to decrease the need for biopsy by about 20 to 30%, and they minimize the detection of grade group 1 prostate cancer, while they miss less than 5% of high-grade prostate cancer. Another challenge with these biomarkers is that they have limited, validation studies in diverse patient population. And the reason why this is important is because of the heterogeneity of prostate cancer, the fact that certain, biomarkers or molecules may have different expression in different patient population. Say, for example, we know Black patients have low ERG expression, and this is a huge component of the ExosDS test and the MPS test, for example. But as I showed you earlier, the MPS has since upgraded to a version 2.0 that included 15 additional targets, and we're waiting for the validation studies in diverse patient population. So what do the guidelines say? How should we use this test? They should not be ordered reflexively. They should be used when they would improve our ability to risk stratify patients to make the decision to proceed with a prostate, a biopsy. They're considered, optional. And in the repeat biopsy setting, in a patient who has a negative biopsy but has a low likelihood of harboring an aggressive prostate cancer, let's say the PSA density is really low, less than 0.1, there will be no need to order a biomarker test in that scenario. However, if ordering a biomarker can further help you risk stratify a patient, let's say the PSA density is elevated 0.2 or 0.3, you're trying to determine whether to repeat the biopsy, then a biomarker could help you make that decision in that situation. So they're considered, optional. And these recommendations are pretty consistent. The EAU guidelines feel that at this time there's limited data to implement them in screening, so they should not be used as a screening test, and there's limited data to recommend ordering them reflexively. Again, the NCCN guideline recommendation is consistent. They are considered optional in this case. So some, important considerations before you order a test. This is how I approach the use of biomarkers in my practice. I ask, what am I getting the test? Is this, test going to tell me information that would help me change management? Often, as providers, we want a test that will tell us yes or no, right or wrong. But as we discussed, this test usually just report a risk score or a probability. And it's important that you have a plan with the patient, what the threshold you use to take action is. And the reason why that is important is because there's some patients, you tell them they have 10% risk of a high-grade prostate cancer. They say, oh, I'm good, no biopsy. Whereas some patients have 5% risk, they want a biopsy today. So you have to have a plan, established with your patient before you proceed. As already mentioned, this tests offer very, very similar data, similar performance profile. There will be no need to order too many tests. They give you very similar information. Or order tests reflexively. I think just use a test that you are comfortable with, that you have access to, that you understand the data for. And importantly, to make sure that the test that you're using has been validated in the patient population of interest. So I use biomarkers, patient preference. They saw it on TV. They want to get a test. I try to convince them. If I don't think it's necessary, they still want it, go for it. I order the test. Or if I'm trying to use a test to reassure a patient, a really anxious patient, provide another level of data to say you do not need a biopsy, I use a test in that scenario. Or a patient with a negative MRI, negative biopsy, but high PSA density, I still have suspicion for high-grade prostate cancer, I use the biomarker. Or a patient has an MRI lesion, you do a biopsy is benign, still suspicious for high-grade prostate cancer, I use a biomarker to decide whether to repeat the biopsy or not. The second part of the talk is germline genetic testing. We know prostate cancer, the etiology of prostate cancer is multifactorial. It can be inherited, and it can also be familial, but no particular gene has been identified as linking or leading to inheritance of the cancer. And in most cases are sporadic, just happen. Some genes have been identified to be associated with heritable prostate cancer, genes like BRCA1, BRCA2, Lynch syndrome, or HOSP13. Why should we offer germline genetic testing to our patients? Well, it helps with risk assessment, what the likelihood might be that they have the cancer. It can provide information as to certain cancers that you can modify their risk, maybe modifying behavior or diet. It can provide prognostic information or even predictive information. For example, BRCA2 patients with metastatic disease may benefit from PARP inhibitor therapy, and it can also inform what additional cancers they should be screened for, or if family members should be screened for certain cancers. Say, for example, a patient with BRCA2 mutation has an 8.6-fold increased risk of developing prostate cancer by age 65. and they tend to develop an aggressive, form of prostate cancer. They also tend to have increased risk of other cancers, as well as increased risk of cancers in family members. Now, how common are these germline mutations? This is a study that was published a few years ago that reported that 17% of patients with localized prostate cancer have some, germline, alteration or the other. But it's important to highlight the fact that there could be selection bias in this data, because these patients were referred for testing for a reason. So this is a highly selected patient population. But another interesting finding here is that the prevalence of this alteration is very similar to patients with metastatic disease. For example, BRCA2 mutation, 44% in patients with metastatic disease and upward of 25% in patients with localized disease. Now, who should get germline genetic testing? Every patient with high-grade prostate cancer or every patient with high-risk prostate cancer or metastatic disease, patients with low risk or intermediate risk prostate cancer, but with presence of intraductal or cribriform pattern should get germline genetic testing, or patients with low risk or intermediate risk disease, but with strong family history of prostate cancer should get germline genetic testing. And this starts with taking an appropriate history, a very detailed history, family history of cancer, their first degree relatives, at what age were they diagnosed with cancer, what cancers were they diagnosed with, and did it lead to death? Did they die from the cancer? How aggressive was the cancer? These are important information that can inform the risk of the patient that you are seeing. And this is a slide provided by Dr. Egner. There are so many tests out there. What I usually recommend is see what tests you have access to, tests that you understand, that you can use, for your patients, and make sure that the key genes that are associated with prostate cancer, are being covered in the test. And this test often can be performed using blood or saliva or buccal swab. They generally can be covered by insurance in the United States, but I understand that it can be as expensive as 2,000 euros in Europe. I learned that this morning, whereas out-of-pocket costs in the United States can be as low as $200. Germline genetic testing can be physician-led or a genetic counselor-led if you have access to a genetic counselor at your institution. Certainly, if you don't, if a patient has a positive germline variant, you want to refer that patient for germline genetic counseling and testing. And the reason why is because they may need screening for additional malignancies, or there may be a need for cascade testing in other family members. And if you don't have access, there's this resource that you can use online. You can actually connect to a genetic counselor online, and this resource has more than 3,000 genetic counselors, and these are resources that you can provide to your patients. So in conclusion, biomarkers improve the detection of grade group 2 prostate cancer, no doubt, but they should be used selectively. They should be, we should be conscious of the fact that they've been validated in the patient population of interest. Should only be ordered if they will change your management, and we want to offer germline genetic testing to eligible patients. Thanks for your attention. All right, so we have some time for question and answer. So if you have a question, feel free to use the mic, and if you're online, feel free to type in a question, and we will address them.
Before we answer, I wanted to, before we answer your question, one point of clarification is that with MPS II, there is a publication out this year, Jeff DeSoyens, the primary author, that indicates you don't have to actually do a DRE with that anymore. And so that distinction between MPS II and other urine biomarkers has gone away. And there are home kits people can do on their own.
Thanks, Dan.
Can you guys comment a little bit about using testosterone on patients with low PSAs? So I practice in a Hispanic population, mostly area, and I have a hard time having, let's say, a patient with 55 with a PSA of 2, and then just tell them, hey, I'll see you in 2-3 years per the guidelines. Before I let them go, I check the testosterone. The testosterone is low. I've seen sometimes when I replace the testosterone, the PSA actually rises, and it gets concerning. You guys have any thought? Because I don't think it's mentioned in the guidelines, I believe.
It's a great question. I have a bunch of thoughts on it. But number one, I think it's logistically sometimes a hurdle to tell someone to come back in 2 years or 3 years if you're going to do the screening. So you have to figure out your landscape, your patient. Is the primary care physician going to do it? Or what we changed in our clinic is we opened up templates and spots 2 years out. We don't have 3 or 4. So there is some kind of trust and compliance that the primary care doc's going to read it or the patient is going to be on top of it. The testosterone issue, I think it's a completely understudied area. If someone's hypogonadal or even in the normal range and low, on how that impacts your screening. And ironically enough, literally within the last week or two, I had some communication because I discovered a paper that was 10, 15 years old out of UT Southwestern that was really provocative. It was Vitaly Margulis. They had given people testosterone as kind of a stress test on their PSA, followed the PSA, biopsied everyone, and if the PSA had jumped up a lot after the testosterone, they were more likely to have a meaningful prostate cancer. And I kind of asked them, because I'd never heard of it, whatever came of this, and it kind of died on the vine and no one did it. So the short summary is no one really knows the answer to your question, but it's really thought-provoking.
I have one more thought about that, which is that as one of the presenters showed median PSA by age, a PSA of 2, irrespective of the testosterone level, PSA of 2 in a 50-year-old man, like you were talking about, is a kind of a red flag. You know, that's a good 2 times the median. And so that's somebody I would bring back sooner, you know, even if the testosterone is not an issue. 1 year max, I would say.
I have a question online, a bit out of scope for the topic. However, do you routinely use biomarkers before active surveillance? So today we're focused on biomarkers for early detection. The biomarkers that we have discussed today have not really been robustly evaluated in the active, surveillance setting. There are tissue-based biomarkers that we're not going to be discussing today that have been, tried in the active surveillance setting. Tissue-based biomarkers like Decipher, Oncotype, or Polaris. And I have my personal, take on the use of those biomarkers. I think patients with grade group 1 prostate cancer, they don't really add, significant value. Maybe some patients with high volume disease or patients with grade group 2 prostate cancer, maybe. But the biomarkers that we've discussed specifically today have not really been studied in the active surveillance population. But great question. I think that a liquid-based biomarker has the potential to overcome the heterogeneity that you see with tissue-based biomarkers, and I would like to see that data. Okay. Any other questions in the room? Yes. Mm-hmm.
Thank you for your great talks, the three of you. You've talked about the number needed to detect to save one life, and it's evolving with time. And what kind of discussion do you have with your patient? Because it not only saves lives or prevents some death by screening, but at some point, some patient will get on ADT and spend a lot of time, years and years, 10 years, 15 years, and they don't die. They're not in the statistics, but their side effects and what happens to them is not taken into consideration here. So I would like to have your opinion about that specific topic, and if as urologists we should, mention that more clearly and include that in the statistics, the percentage of patients that will be lifelong on ADT and the cardiovascular side effects and everything on erectile function, libido, and everything.
Yeah, thank you for raising that nuanced point. I agree with you that morbidity is something that we often forget in these discussions. And, I serve on many different guidelines, and we often, try to bring that back as an endpoint to look at. And so, screening definitely reduces the risk of developing metastatic disease. And like you said, these men can be in those health states for many, many years and suffer from the side effects of hormonal therapy and long-term consequences. So I 100% agree with you.
Sorry, do you include this in your discussion with the patient outside of just, because we often talk about the primary treatment, erectile function, incontinence, and whatever comes with the primary treatments, but I don't think that most people will include the risk of getting on ADT. So do you include that discussion with the patient? Anyone here?
Personally, I don't routinely include that, in the conversation unless the conversation leads there, right? Like, for shared decision making, I outline what the benefits and the harms of screening are. And really, I agree completely with Dr. Carlson and yourself. I think, we're focused on the hard endpoints, but the morbidity, I think, is key. Usually those conversations I include when talking about treatment for the disease in patients that are already diagnosed with cancer. If I think that they should pursue with treatment and they don't want to, then I tell them what might happen if they develop metastatic disease. That is when the discussion about the morbidity from treatment comes into play.
Thank you.
Hi there. Just wanted to see, is there any data that you all know of for, I guess, how quickly a PSA can rise within a screening interval? I just ask because sometimes you get these guys who are, I just inherited a patient recently, 82 years old, PSA on dutasteride, rock steady for years and not worrisome, and then it comes back and it's 22 just 1 year later. So those are kind of the things that scare me, and I know they're rare, but when they do happen, they're profound. So is there any kind of data or way to think about this to try to minimize that risk?
I think there's a great old slide that's been shown by everybody who gives prostate cancer presentations about screening intervals and which types of cancers you can catch, right? There are some that are crawling along like a turtle, and you could screen every 5 years and catch them. And then there's some that soar like an eagle, and no matter how narrow you make your screening interval, you're not going to find those. And the way that I'm speaking for the epidemiologists, we have one right here, but the way they think about it is, at a population level, with what maximizes the benefit and minimizes the harm. Yes, we could screen everybody every 6 months to find that one guy, but that would put everybody through a lot of unnecessary testing and potentially unnecessary treatment. And so you find a happy medium where you're going to miss the fewest, but minimize the amount of testing.
Luckily, those interval cancers are very few in the screening trials. I don't know, in your experience as urologists, PSA has a tendency to jump up and down, as you showed in the EastHam study. When something goes from low to very high, what I know about prostate cancer is that it's usually something benign, like a prostatitis or UTI or something else. Is that your experience?
Did that patient you just discussed have a bad cancer, or was it a false alarm? Yeah. Yeah. The data that's available when there's a big spike is it's usually not cancer related, but it can be. And so I always repeat it. I have traditionally given empiric ibuprofen for a period of time. We are almost done with a randomized trial. I have no idea whether that's going to be helpful or not. It seemed like a low risk potential benefit to try to get rid of any subclinical inflammation. I'll let you know what that shows. But for a patient like that, I would, check a urine, maybe do some ibuprofen if they can take it, check another PSA 2 months from there and a free and total PSA and take it from there. And if it's coming down, sometimes I'll keep, in an 80-something-year-old, I'll keep slow playing it and just kind of see where it peters out. Now, if there's a true abnormal diarrhea, that's a different scenario, and maybe he's one of those outliers. That's an unfortunate situation.
Yeah, so regarding PSA density, in a patient who's say, 70 years old, in that range, is there a low level of PSA density that you'd feel comfortable with discontinuing screening?
I don't think we've seen any data with PSA density level and when to discontinue screening. But with absolute PSA value, for example, in a man who is in the 60s with a PSA of less than 1, you could consider discontinue screening. Or a man in his 70s with PSA of less than 3, you could consider discontinue screening. But I don't think I've seen any data about PSA density level and when to discontinue.
I think it's an extraordinarily important question that is largely understudied. It'd be great to have tangible answers. I have a talk that I give on when to dial back or discontinue screening and try to be as data-based as possible. The data that we have, which is very limited, at age 60, if your PSA is less than 1, the likelihood of being diagnosed with a worrisome prostate cancer, and this is an unscreened population, over the next 25 years is 0.5%. So I would dial back on those folks or stop or go every 5 years. We have the data Dr. Carlson showed that if you're age 75 with a PSA less than 3, and then a lot of the patients, it's just kind of what you're alluding to. You kind of know it when you see it and you ballpark it, and there's no magic number for PSA density or PSA, but I try very hard to tell them to, discontinue or at least be less aggressive. And then the only other nugget there, this is the most obvious thing ever, but it changed, when I saw a study like this, it changed how I do it. Don't say you're too old, you're too sick. You frame it more so as this is really unlikely to help you, way more likely to torture you. Let's, reconsider.
Okay, we'll take one more question. Oh, sorry, go ahead.
Just continue. We do so many MRIs now, so we get PSA density, so we see it all the time. So in many of the European guidelines, PSA density is included in the algorithms. So
I'll talk.
So Dr. Barkas will cover that. And, but whether you should use 0.1, 0.15, it's up to debate. And you can definitely use that to determine the need for biopsy also.
Okay. To piggyback on the discontinuation of screening, for men who have a abnormal PSA and then undergo an evaluation, so they have an MRI and they have a very thorough evaluation, MRI, biomarker, maybe even a biopsy, and it's negative. Can you comment on discontinuing screening on those men? Like, do you follow them every other year still, every year? Is there ever a point where you just say, not going to develop prostate cancer, you've had a very thorough evaluation, I'll see you later?
So we can talk more about it when we review some of the other guideline statements, but basically a prior negative biopsy and the evaluation you're describing, no doubt that reduces the probability of finding cancer in the future, but it doesn't eliminate it. And so one of the guideline statements says don't discontinue screening just because of a negative biopsy. And on the other hand, don't do a repeat biopsy based on PSA level alone. In other words, if you did that evaluation because the man's PSA was 8, don't repeat it again next year just because it's still 8, because your yield is going to go down.
I would add one other thing. There's one very large Danish study that was very encouraging and talks to your point. Once someone's had an elevated PSA and a negative prostate biopsy, those, before the biopsy, they're higher risk than the general population because their PSA is higher, right? Once they have that negative biopsy, their risk of having badness from their prostate cancer just immediately dropped and is equivalent to the general population writ large. So you can interpret that however you want. You either dial back, or if they're already kind of on the cuff of, stopping, you might just stop.
All right. We'll move on now to talk about MRI for prostate cancer detection. I'm Dan Barocas from Vanderbilt. These are my disclosures. I don't think any of them is relevant to what we're talking about today. So why MRI and prostate cancer diagnosis? Finger-guided biopsies are out. By the way, the AUA is very strict about references, so that is my finger. It's a little crooked, but that is my finger. Finger-guided biopsies are out, and we're left with image-guided ultrasound or MRI-based biopsies. And as you know, MRI-guided biopsies can be done in the scanner. Those are not particularly common, or they can be done as standard office or surgery center-based transrectal or transperineal, either using cognitive fusion, meaning look at the MRI, then look at the active ultrasound and aim for the lesion you've seen on the MRI, or they can be done by MRI ultrasound fusion using specific software. This is not a course in how to read an MRI, but it is important that we familiarize ourselves with this. This is just like looking at the kidney tumor before you do a partial nephrectomy. And I'll run through this briefly. I think you all know that we use what's called the PIRAD system to rate how suspicious a lesion is on MRI. It runs from 1 very low probability to 5 high probability. And the components are these phases: T2, diffusion weighted, what's called ADC map, and contrast enhanced. On the T2, it's dark. It doesn't project too well in this bright room, but dark on T2, bright on diffusion weighted, and again, dark shadow on the ADC map. And finally, maybe the least important of these is the early enhancement on the dynamic contrast enhanced. This is then a PIRADS 5 because it meets all those criteria and it is above a certain size. But I do think it's important. Radiology is quite variable, particularly if you're going to be doing cognitive fusion biopsies. They don't always mark the area well. You have to be able to read it yourself. So why do we use MRI to guide biopsies? Mainly to detect, to direct biopsies at regions of suspicion for tumor, but perhaps also to avoid doing systematic core biopsies in the setting of a positive MRI, in other words, aim only for the target, and maybe to avoid biopsy altogether in people with a negative MRI, and we'll talk about those things. So with the AUA guideline, what does it say about using MRI in the initial biopsy setting? So if someone has an elevated PSA, it's confirmed, what do we do next? MRI in that setting is considered optional. I will say I use it almost all the time, but it is optional in the initial biopsy setting. And so the clinician may use MRI prior to initial biopsy to increase the likelihood of detecting a grade group 2 or higher prostate cancer. And what do we do with that information? In the guideline currently, it says that if it's positive, if it's negative, we're going to go ahead and do a systematic biopsy. In other words, MRI negative, we're still going forward with the biopsy in the initial setting. So the systematic biopsy is required there. If there is a finding on MRI, then we aim for the target plus minus the systematic biopsy. So in that setting, we're taking at least 2 cores of the lesion and plus minus doing the systematic biopsies. And what does this depend on? It depends, first of all, that we know that the detection of clinically significant prostate cancer is enhanced by the use of MRI. These are all very differently designed studies, and that's why the range is so wide here. But no matter how you look at it, using MRI increases detection of grade group 2 and higher prostate cancer. This is from the systematic review performed for the guideline panel. And what you can see is that risk of clinically significant cancer is correlated with this PIRADS score. So 1 or 2 is essentially a negative MRI, and the likelihood of finding clinically significant prostate cancer there is very low. As you go up to PIRADS 3, it's about 11%. About a third of people with PIRADS 4 will have a clinically significant cancer, and about 70% of people with a PIRADS 5. So we're using it to increase the detection of grade group 2 disease. And as I said, that we do recommend performing the systematic biopsies in the setting of a negative MRI, and that's this statement. But in the setting of a positive MRI in the initial biopsy setting, that systematic biopsy is negative. And so the rub with doing the systematic biopsies is the following. It increases, in combination, let's say, with the targeted biopsy, it increases detection of clinically significant prostate cancer by 10 to 15%, meaning that 10 to 15% of meaningful cancers are not detected on MRI. MRI can have false negatives. However, if we do those systematic cores, let's say in the setting of a negative MRI or in the setting of a positive MRI, and we're adding the systematic cores, we're actually increasing the detection of low-grade cancer by 50%. And those are the cancers we don't want to find. We don't want to know about those and torture people with repeat biopsies for the rest of their lives. And it puts everyone through a biopsy. In other words, it'd be great if a negative MRI got you off the hook for doing a biopsy. If we do the targets only, in other words, omit the systematic biopsies when the MRI is negative, or when it's positive, it reduces that overdiagnosis of grade group 1 prostate cancer, but potentially misses important cancers. If it were reliable and we could count on it, however, it would reduce the biopsy rate significantly. So that's the initial biopsy setting. Let's talk for a minute about after the initial biopsy is negative, and we're thinking about repeat biopsy for ongoing concern. In patients who are undergoing repeat biopsy and have not had a prior MRI, we do recommend that they obtain an MRI prior to biopsy. So here, that's kind of required in the second biopsy setting. There is a difference, however, and so in the repeat biopsy setting, MRI will show a suspicious target 36 to 90% of the time. MRI will be, and biopsy will then be positive a third to 2/3 of the time in the setting of a positive MRI. And a substantial proportion of those are grade group 2 or higher. There are differences in how we treat the negative MRI in this repeat biopsy setting. For those who do not have a suspicious lesion on MRI, the clinician may proceed with a systematic biopsy. In other words, the systematic biopsy is optional in that setting. And why is that? Again, the repeat biopsy setting, as we talked about, is lower probability to detect meaningful cancer. And so we felt more comfortable allowing for the omission of these systematic cores, again, with the caveat that MRI is not perfect and can miss up to 10 to 15% of grade group 2 or higher biopsy, grade group 2 or higher prostate cancer. So ultimately, you have to decide on whether to do a biopsy based on repeat biopsy or the systematic cores in the setting of a negative MRI based on other factors like PSA density, other biomarkers, or a nomogram. For those who do have a suspicious lesion on MRI, again, it's the same. You do the target and plus minus the systematic cores. Maybe we can get into a little bit of debate here about who does the systematics in the setting and who doesn't. So the targeted biopsy required, systematic template biopsy optional in that setting. And why, again, because we may find those hidden cancers that MRI does not detect. However, the additional cores add time, cost, patient discomfort, and again, the detection of grade group 1 disease. So this question of can we omit the systematic biopsies? We alluded to this earlier, that the European guidelines are different from the AUA guidelines. In the AUA guideline, biopsy history determines what is done. And there are no specific recommendations against doing a biopsy. So for example, in the initial biopsy setting, you may or may not perform the MRI. In the repeat biopsy setting, you do if it hasn't been done previously. In the initial biopsy setting, when the MRI is negative, we do recommend doing the systematic cores. In the repeat biopsy setting, those systematic cores are optional in the setting of a negative MRI. In the setting of a positive MRI, in either the initial or repeat biopsy setting, we recommend doing the target plus or minus the systematic cores. And what's different about the EAU guidelines is that they incorporate PSA density, which is an interesting concept we'll elaborate on a little bit more. But MRI is required before a biopsy for all scenarios. For a negative MRI, if your PSA density is low, they actually recommend against doing a biopsy. And this is sort of like a double negative concept. The biomarker, in this case, PSA density is negative, and the MRI is negative, and so the probability of finding cancer is quite low. If the MRI is negative, but the PSA density is quite high, there you should consider it based on other factors. In the setting of a PIRADS 3, sort of a low probability lesion identified on MRI, again, if the PSA density is very low, they recommend no biopsy. If it's higher, consider, and if it's high, do a targeted biopsy. And then for truly positive PIRADS 4 and 5 MRI, they recommend targeted plus or minus perilesional. Now, they're not recommending a full systematic template. They're recommending biopsies of the target and around that same area. So interesting differences between the two guidelines. The European guideline is based primarily on this study and others like it, Schutz et al. where they did this. They looked at PSA density and MRI findings, and again, very low probability if the MRI is negative and the PSA density is low. Whereas, if you look at the PIRADS 3 area, it's most interesting, where with a low PSA density, you're down to about 4% likelihood of finding grade group 2 or higher disease, whereas if the PSA density is high, you're up to about a third of folks having a clinically significant prostate cancer. So this is an interesting paradigm, and I think Dr. Carlson will get more into the idea of using a biomarker and MRI in conjunction. So this is a study that sort of mirrors that difference between the EAU and AUA guideline. People with a PSA greater than 3 underwent MRI. They were randomized either to a reference group where they got a systematic biopsy if the MRI was negative, or targeted plus systematic if the MRI is positive. This sort of mirrors the AUA guideline. And then the other group got no biopsy if the MRI was negative, and targeted only if the MRI was positive. And what did they find? They found that that biopsies were performed about half as much in the experimental group as in the referent group, either with the MRI positive or with the MRI negative. They found that clinically insignificant prostate cancer diagnoses were about twice as high in those who got the systematic biopsies, and that the detection of clinically significant cancers was preserved in both groups. So in other words, nothing lost on identification of clinically significant prostate cancers, but half as many people underwent biopsy, half as many clinically insignificant cancers were identified. And I won't go through it in detail, but 4-year follow-up basically showed the same. What about the difference between cognitive and computer fusion? The guideline reads that clinicians may use software registration of MRI and ultrasound images during fusion biopsy when available. In other words, we have not found much difference between cognitive fusion and computer fusion. And the computer fusion machines are very expensive. We can use them if they're available, but we need not if they're not. And this is one such study demonstrating no difference between computer fusion, which is in orange, and cognitive fusion, which is in blue. So summary of the AUA guideline recommendations. MRI is optional in the initial biopsy setting, required if not previously done in the repeat biopsy setting. If the MRI is positive, targeted biopsy is required in either setting, and systematic biopsies are optional in either setting. The difference here is that when the MRI is negative, we do recommend systematic biopsy in that initial biopsy setting, but it is optional in the repeat biopsy setting. We do recommend at least 2 or more biopsies per target, and probably after 3, it's diminishing returns. And again, computer or software registration is fine. All right, and that's my talk. Thank you very much.
A question for you?
Question, yeah.
Two.
Okay, can you wait a couple of minutes?
Sure.
Sorry, cliffhanger. We have more time for questions later, so yeah, thank you. Okay, so let's talk about how we can integrate what you've learned so far. So you've seen my explosion slide before. Maybe this is the 3rd time we're showing this in this course. So the take-home message is that the market is growing. And MRI, as you've heard from Dr. Barkas, really has been a game changer. It really improves the balance between the benefits and harms of early detection. And what it does is that it maintains the detection of significant disease, it reduces overdiagnosis, and it reduces unnecessary biopsy. So really, it's really been a game changer. And I think we more and more see men come in with MRIs in our practices. But for this concept of pre-biopsy MRI to work, it's really important that the chain is only as strong as its weakest link. So we're doing a lot of MRI scans and we're doing a lot of biopsies and many unproductive biopsies, and there's a high reader variability. So we really need access to good scanners, and we need to be friends with our radiologists and know their outcomes and know their negative predictive values and talk to them. And so we really have to have some quality assurance when we use MRI. And we know that experts have better readings than non-experts. There's an example, again, from the ProBase trial in Germany, where you can see that experienced readers have much higher accuracy than local readers. And what's really interesting and up and coming, I think, in this space is the use of AI to help us interpret these images. And whether that's assisting the radiologist or it's used without, I think it's mostly will be used in conjunction with the radiologist. But it can really help, improve our both accuracy, access, and also efficiency. And in Europe, for example, where we are now doing population-based screening programs and implementation pilots, the number of MRIs needed to be done and the resources required, it's not going to be feasible without some type of automation. And so the concept of combining biomarkers and MRI can look something like this. And the whole idea is to minimize the harms on a population level. So if we have our target population here, and then we do a simple blood test, as Dr. Eggener mentioned, simple and cheap and fast, we can then use a reflex test in between, and that can reduce the need for MRI. And then we go on to the MRI, and we can decide, if we learn from Dr. Baracus how to perform the biopsy. And that way we can have a more efficient strategy that finds the cancers that we want to find, and that we don't put needles in prostate and find the indolent cancers. And so you saw the Göteborg 2 trial that I'm also an investigator of, that reduces the risk of overdiagnosis and keeps the detection of significant disease by only putting needles into what we saw on the MRI. And as Dr. Baracus mentioned, when men come back 4 years later, we still have a reduction in overdiagnosis without missing interval cancers. As somebody mentioned before, what's the risk that somebody comes back with a bad cancer in the meantime? And that is, the risk when we have somebody with a negative MRI or a negative biopsy. But the key here is that we have a safety net. So these men come back for repeated screening, and therefore, instead of missing them, we can delay the detection of high-risk disease. And here's an example from the ProScreen trial, and we have also done similar studies in the Göteborg 2 trial using the 4K score, which comprises, as you know, of 4 kallikreins combined with clinical information. And if you use this as a reflex test between the PSA and MRI, you can see that you reduce the number of scans needed by 30%. And if you then those men go on to MRI, you have then 50% fewer biopsies. So it's really making the whole chain more efficient, and the negative predictive value of this chain is 99%. Similarly, the Stockholm 3 test, it's available in Sweden and other places in Europe. It's also a multiplex test, so it combines clinical risk factors with protein biomarkers and also has a genetic component with PRS and also some other genes. And the similar is that you can see that it improves the specificity if you combine it with MRI. And you can see how you reduce the number of biopsies, overdiagnosis, but you still keep the detection of high-grade disease. And as I mentioned, in Europe, it's very interesting at the moment because there's a large-scale initiatives for screening led by Professor Monique Robol, Professor Hein van Poppel. It's called the PRAISE-U, and many countries have joined this initiative, and I'm part of the Swedish component of this, and many other countries are set to follow. So it's an interesting space to be in right now because we have moved from the trials into the evidence and implementing it into clinical practice. So some more and more screening is happening in a more risk-stratified way. And if you look at it in 2025, all of the ongoing and recently completed trials on screening now includes some type of risk stratification, and most of them include MRI. So this is really the modern way to screen. Thank you.
Okay, good afternoon. I'm Kara Watts from Montefiore Medical Center in the Bronx, New York, and it's a real pleasure to be here with these esteemed faculty and have the opportunity to present to you this afternoon, so thank you very much. I'm going to speak to you about prostate biopsy techniques and what you need to know. This doesn't work. I see that. Okay, so the learning objectives are 1, to employ safe biopsy practices with respect to approach, avoidance of infection, and sort of patient comfort, to review transperineal and transrectal prostate biopsy, and some follow-up for pathologic findings. So I start with a very simple statement that the safest prostate biopsy is frankly the one that is avoided. And you're hearing throughout this session here about avoidance of diagnosis of clinically insignificant disease. So if you look at guideline statements 11 and 18, when the risk of significant prostate cancer is sufficiently low based on all of these parameters, patients may forego near-term prostate biopsy. And for patients with the PSA over 50, and no clinical concerns for infection or other cause for increased PSA, then you may also omit a prostate biopsy and perhaps just proceed to treatment. What are the goals of a prostate biopsy? Well, the goals are the same as we've been hearing this course: to identify clinically significant prostate cancer and to minimize detection of clinically insignificant prostate cancer. So statement 12, clinicians should inform patients undergoing a prostate biopsy that there is a risk of identifying a cancer with a sufficiently low risk of mortality, not speaking about morbidity, that could safely be monitored with active surveillance rather than treated. So I'm going to review a little bit about prostate biopsy preparation and antibiotic prophylaxis. The goal, without doubt, is to avoid sepsis. And so there are some general principles to consider. The first principle is that one of the most common antibiotics used is fluoroquinolones, and there is a dramatic rise in resistance to fluoroquinolone, particularly amongst E. coli. And so one of the most important principles of selecting your antibiotic for your patient population is consultation with your local antibiotic resistance data, and also to avoid the overuse of antibiotics as resistance is on the rise. It's one of the biggest threats to human health that we face today. So if you look at what the recommendations are, this is antibiotic recommendation for prophylaxis for transrectal biopsies, not transperineal. So the antimicrobial of choice is a fluoroquinolone or a first, second, or third generation cephalosporin, perhaps with an aminoglycoside, and the duration of therapy recommended is a single dose. Now, there are additional approaches to minimize your risk of urosepsis with a transrectal approach, and one of them is the augmented antibiotic approach, which would be conventional antibiotics such as a fluoroquinolone plus parenteral, either IM or IV gentamicin. You could do culture-directed, which is obtaining a rectal swab before, and then depending on what bacteria grow and what they are sensitive to, prescribe based on that. And if, in systematic reviews, if there is a very high resistance to fluoroquinolones in your particular area, fosfomycin is an effective alternative to consider. Now, what about transperineal biopsy? This is slightly different. This is a class 1 risk for infection afterwards, and so the recommendation is 0 to 1 dose, so it can safely be omitted. You do need to consider covering skin flora, and as always, consult your local antibiotic resistance data. There are a couple of special cases to consider if somebody's had a prosthetic hip or knee within the most recent 2 years, if they have very high risk factors for infection, sort of immunocompromised, or if they've had recurrent urosepsis or UTI episodes in the past and you have culture data for that to drive your choice. In addition, if they are colonized, so if they have a chronic catheter, an indwelling catheter, they don't walk at baseline with infection, but they are colonized. And so you may consider extending your prophylaxis, cover the day before, and potentially up to 4 days. What do you do about anticoagulation and antiplatelet agents? So if you do continue the use of anticoagulation, there is on average about a 2 times risk of bleeding complications. And so the recommendation is to hold anticoagulants or antiplatelet agents if and when possible. The duration for how long you hold them depends on the half-life of the agent. Certainly if there's somebody who's had a recent cardiac stent and occlusion of their cardiac stent within the first 6 months would be very high, you also have to consider the risks of holding their anticoagulation and consult with their cardiologist. Other considerations for reducing infections. So this is a systematic review and meta-analysis that looked at other things that you may do to reduce your infectious risks afterwards. There is some data to support doing a rectal prep with iodine beforehand for transrectal biopsies. There is no data to support either an association with infection with the number of cores you take, the number of nerve block injections that you give, the needle type, the needle guide, or the use of an enema. But I will say that the overall data quality from this meta-analysis was reported as quite low. So, by a quick show of hands, who in the room does transperineal biopsies? Okay. By a quick show of hands, do you do transperineal biopsies to reduce risk of infection? Raise your hand if yes. Do you do them to enhance your detection of cancer? Okay. So, infections after biopsy. There is 4 RCTs that have compared transrectal and transperineal biopsies published in about the last 2 years. So this is some of the most current, highest level data that we have. And they compared both cancer detection rates as well as complication and infection rates after. What we see is actually that in terms of hospitalization, sepsis, infection rates after, there was only one study of the 3 that showed a difference in infection rates afterwards. And the absolute difference, if you look at all of the studies combined between transperineal and transrectal, is about 0.9% favoring transperineal biopsies. The caveat to this that I would say is you have to look at the window, the timeline that they are reporting these at. These are out to typically 3 or 4 months after the biopsy. And if you look at the Translate study, if you look at their infection rates between the two, local anesthesia transperineal versus truss, at 7 days, there was quite a large difference, less than 1% versus 1%, 1 versus 7 patients, and even at 35 days. So you do have to consider what the time frame is that you're looking at these data. Comparing the 2 biopsies also, you will have a higher risk for rectal bleeding after truss. You certainly don't get that after transperineal biopsies. Transperineal biopsies are associated with more pain and patient-reported anxiety if they're done under local during the biopsy. So you have to consider that and incorporate that into your counseling. And a lot of that, I think, could be mitigated just with your approach in counseling beforehand. Okay, so I would say the debate continues, transperineal versus transrectal. We heard before EAU recommends doing transperineal. Strong recommendation. AUA, consider either one. Grade C. So looking at the cancer detection rates between these 4 RCTs, 3 of the 4 showed no difference in cancer detection rates between each of the approaches. However, when you look at the Translate trial that just was recently published, they actually found a higher rate of grade group 2 and higher cancer detection in the transperineal arm, and that was statistically significant. And that was not because of anterior lesions, it was agnostic to location within the prostate. I'm going to skip these slides because Dr. Barocas just went over all of this. The biopsy or targeted biopsy fusion, however you want to call it, targeted cognitive fusion or image fusion, the points to just remember are you may use software registration or you can use cognitive fusion, and I think that's very skill dependent and your ability to read and understand MRIs, and that if you're going to do target biopsies, you should get at least 2 cores from the sample. So getting into a little bit of technique now, transrectal ultrasound. You're going to insert the probe with some sort of posterior pressure into the rectum, and you want to keep the ultrasound gel at the transducer head because you need that to have good visibility of the prostate. There are 2 types of probes. Dr. Barocas went over this as well, side fire and end fire, depending on how you want to perform your biopsy. Always start with anesthetic first, unless you don't like your patient. And you certainly can start with a prostate volume measurement, height times length times width. If you already have volume from an MRI, I would argue you perhaps don't need that. And just start with a quick scan of the prostate. Are there any hypoechoic lesions that perhaps was not seen on the MRI, or large calcifications that you may need to consider? For the transrectal local anesthetic injection, so you have, I'll show you a video in a moment. This is the anatomy here of the prostate with the interfascial plane to non-venous fascia and your neurovascular bundle on the lateral sort of pedicles or angle. And this triangular space, which is right here, this is the seminal vesicle here, and the prostate is exactly where you're going to do your injection. So this is probably quite simple for most people in the room, but it's a nice demonstration. Here's prostate in axial view on ultrasound. Scanning through, you see sort of the peripheral zone here at the bottom and the transition here to the central zone with some calcifications or hyperechoic areas there. And here you can see, this is right there, that this is the very lateral corner of the prostate, and that is that triangle right there. So I'll just move on for the sake of time here. Now, what is the best biopsy template to perform? Still, for a transrectal ultrasound, the 12-core biopsy is what is recommended, and it's still recommended to place from the 6 sextants the cores into 6 containers as opposed to separating them into 12. From a environmental sustainability perspective, I also love that recommendation. If you think about anatomy in the prostate, there are limitations of transrectal sampling, and it's not a surprise that lesions that are anterior or lesions that are very apical have a risk of being undersampled or inadequately sampled with this approach. Now, moving on to transperineal biopsy and anatomy overview. This is the way you would be looking at a prostate from the transperineal approach, and also the percentages of where the likelihood of finding prostate cancer are. So really the peripheral zone, which is posterior and lateral, and to a much smaller degree, 20%, the transition zone in the anterior portion. This muscle layer, here the levator ani are the muscles that you will be piercing with your needle every time you go into the prostate to take a sample or to inject your local. Now, the optimal template for a transperineal biopsy has, it's a little bit more debated. It's not just the one 12-core template that we have for the truss biopsy. The MUSIC transperineal prostate biopsy is one that I use in my practice. It is 12 cores. It heavily samples the peripheral zone and also additional samples from the right and the left anterior or sort of transition zone. There is also the modified Barzell template, which is up to 20 cores. And where I think this can come in handy is if you have a very large prostate. So you are sampling, the B here is for base and the A is for apex. You are sampling separately the base and the apex so that you're getting adequate sampling of both halves of the prostate. And this is just another visual, which I think is helpful, and I try to draw this for my residents when I teach it, the sort of the transperineal fan template. This is a 12-core biopsy. Now, limitations of transperineal biopsy sampling. The real limitation here is essentially at the base. Your needle has to traverse all of this tissue to reach this basal area here by the bladder, the same way a transrectal biopsy would have a hard time traversing all the tissue to reach anterior tumors. So what do you do for a setup? Now, for transperineal biopsy, there are a number of ways to skin a cat, and I'm not going to comment on which way is best. I think this is extremely provider dependent, patient comfort dependent, equipment dependent. You can do it under local in the office. You can do it with sedation in the, a surgery center. You can do it with a stepper and a grid. You can do it freehand. I'm going to talk about these briefly, but this is a setup that I have in our surgery suite here for transperineal prostate biopsy with light sedation. So I have here my lidocaine. This is their opsite strip for the end, some chloroprep for prep. Here's the Telfus for... What? I don't see it.
Maybe all the way.
Oh, wow. Sorry, I've been pointing at things and none of you have seen it. I'm so sorry. Okay. Wow. Good to know. Okay, so this is a picture of a grid, a template grid, which I actually think is incredibly useful if you're learning how to do transperineal prostate biopsies, because it sort of guides your needle and avoids the need for you to sort of struggle with using two hands simultaneously and get them to work in sync. This is really allowing you to focus on just the hand pushing the needle. You do need to elevate the scrotum out of the way, and this is my poor man's version of a scrotal hammock. I just take a blue towel, get it wet, roll it up, lift up the scrotum, and it works beautifully, and it doesn't really cost anything. This is the transperineal freehand approach. So this is not using a steppering grid. This is an ultrasound probe going into the bottom, and then using the needle either completely freehand or with a needle guide, which I'll show you. In my room, when we have it set up, I have the ultrasound image here, and I always have the MRI images with the lesion right in front of me, so we're constantly taking into account what we're sampling. Single point entry access systems are really convenient. There's a cost to them. And so what these allow for is you to make a single puncture on each side of the prostate to sample one or two punctures on each side to sample without having to poke the skin each time you take a sample. This is skill dependent, but I think this is ideal if you're going to do this awake under local to minimize the number of times to pierce the skin. I'm going to play this video. This is not me in the video. This is Dr. Wei, who previously taught the course. This is his video. So here you can see he has the scrotum elevated. The patient is in lithotomy. These are done in lithotomy. The perineal skin was initially prepped. He started off with sort of a subcutaneous local injection to the perineum, and here he is piercing the skin with the spinal needle to give the deeper block around the prostate. And so here you can see on the video, the needle is, here we go. So the prostate is down here. You can see the seminal vesicles here. And you can see his needle coming in right here. He just pierced through the levator ani there. That's sort of this plane right here. You draw back, make sure you're not in blood. And then the nerves that innervate the prostate are about 2 centimeters off the midline on average. And so you want to inject in that plane between the capsule of the prostate at the apex and the levator ani. And then, your template that you use is really up to your desired, your technique or where you're trying to sample. Okay. And we just went over that. So this is another nice video just showing you, this is the needle coming in here at the apex. This is a posterior sampling. And so, the needle went to about this point of the prostate. If you have twice that length, going toward the base, then you may need to do also a separate base sample to make sure that you're adequately sampling. Now, what to do about post-biopsy follow-up? This is kind of an obvious point. Review the results promptly. You should communicate your results to the patient afterwards. Reassess their risk of undetected or future development of at least grade group 2 or above cancer. So it's not a negative biopsy means see you never. And decide on whether to discontinue screening, continue screening, or do adjunctive testing. And we went over this before. You should not discontinue prostate cancer screening based only on a negative biopsy. Just a couple of pathology points, and then I'll be done here. Pathology, yeah, of course it matters. Unifocal versus multifocal high-grade PIN. So, high-grade PIN is considered a precancer or sort of a CIS equivalent. Monofocal, if it's one core only, you can follow that with a PSA. If it's multifocal, at least 2 sites, then you do need to consider having a closer follow-up for them. It doesn't mean cancer, it does not mean treatment, but perhaps have a lower threshold to follow up. For ASAP, this is not cancer, but the risk of Gleason 7 or higher is about 10%. And so consider your repeat sampling or an MRI within 6 to 12 months. And then if nothing on the repeat, then continue normal screening and surveillance. PIN or atypia has a very similar risk profile to ASAP. And inflammation in granulomatous is benign. So follow-up after a negative biopsy, this is reiterating what you've heard. Can the patient be followed with a PSA? Well, you don't want to only use that in the same way that we don't only use a PSA velocity to guide a biopsy. You want to use other clinical factors, perhaps imaging or other biomarkers to make your decision. How often should you be followed? We already went over this with the 2 to 4 years. And how do you estimate their risk after a negative biopsy? You can consider using a risk assessment tool for that. So in conclusions, there have been a number of advancements in both transperineal and transrectal prostate biopsy technique. We're seeing a much broader use now of transperineal and frankly, local anesthesia, transperineal biopsy. Antibiotic prophylaxis is absolutely key, especially for truss. You may omit them in transperineal. Everybody talks about infection rates after these two. What nobody talks about is the overall population health benefit of TP biopsies in the sense of not giving antibiotics and mitigating the risk of antibiotic resistance that continues to challenge us. Know about your local anesthetic technique. This can vary depending on indication and risk. And then obviously proper follow-up. Thank you very much.
Thanks, Dr. Watts. Very well done. I think what we're going to do is take the next 10 minutes to go through maybe a couple of cases. And then during that, it will be interactive. We can take questions during that as well. So let's... So I'll have you scan the QR code because there is one polling question. All right, looks like pretty much all set. So first case is a patient that was referred to us, essentially a healthy patient with no family history of prostate cancer. And what you see here is a PSA trend. I'm going to show you what was done prior to the patient being referred. At the time the PSA went to 6.5, he had an MRI that was negative. PSA density based on that was 0.2. He had a systematic biopsy because of his elevated PSA. PSA density was atypia, ASAP, as you just heard. PSA continued to rise, went up as high as 15.9. So based on the previous MRI, the PSA density would be 0.42 at this point. And the question is, what would you do next? Would you observe with serial PSAs, antibiotics, biomarker testing, repeat the MRI, or proceed to biopsy? All right. This is great to see. You would not continue to observe with serial PSAs. You would not give antibiotics, Dr. Egner. That was well done. Biomarker testing, 12%, and then repeat MRI. So CTE. So let's go through that. So I'm just going to go ahead and knock out, observe with serial PSAs, no antibiotics. So the question about repeat MRI is debatable, right? Like the MRI here is just about a year or less than a year old, right? It's like the likelihood that you see significant change on the MRI is low. There is data from the NIH that suggests that MRI probably 2 years, no more frequent than 2 years. Dr. Biomarkers, any thoughts on that?
Agree completely. I usually don't. The only caveat to that is that if someone has come from elsewhere and I'm not confident in the MRI read, it doesn't look like a good quality MRI, and I'd prefer to have one done at our institution. That's the only caveat.
Yeah, good point. So I'll tell you what happened and what we found. So this patient actually he had a repeat MRI prior to this patient getting to me. And the MRI did show evidence of, prostatitis. He got 4 weeks of antibiotics. We've said, don't do that. It didn't make any difference in this case, right? PSA went down to 13.1, still elevated. So what I did was to get a Michigan prostate score at the time because this was developed at the University of Michigan. So 65.2% risk of high-grade prostate cancer. And we proceeded to do a biopsy. I don't have a question about this, but in the room, what kind of biopsies will you do?
May I comment on that?
Please.
Most of the biomarkers, and I think MPS may be the exception, most of them are validated and only paid for by insurance within a set range. And I think for many of them, that range tops out at 10. MPS, I think, will allow you to run the test at higher PSAs in the setting of a prior negative biopsy. And I don't think they're all the same in that regard.
Yeah.
So MPS was a good choice in this situation.
Yeah. Okay, so Dr. Watts, any thoughts on what kind of biopsy you will do here?
Well, I think you just prompted me to do a biopsy with that question. I mean, I think if your concern is that high, the other test you could have done, you could consider would be a confirmed, DX tissue base to look for the likelihood of clinically significant cancer that is there. I think at this case, if your suspicion is really that high, you can consider doing a template biopsy, and it wouldn't be 100 samples because his prostate's pretty small, but just to be thorough.
Yeah. Okay. So good thoughts. So what we opted to do was to do a mini, saturation biopsy. And the thinking here was that like Dr. Watts mentioned, the prostate is, small. It's like 38 cc. So just to map out the entire prostate, and he did have a grade group 3 prostate cancer. So the learning points here are, I think, using biomarkers, judiciously in the setting of repeat, in the setting of a prior negative prostate biopsy, but with rising PSA or ongoing suspicion for high-grade prostate cancer. Any questions about this case from the audience? We have like a minute. Correct. Anterior. Mm-hmm. Yeah, so excellent comment. So for those listening online, the comment or the question was where the positive biopsies in the anterior region of the prostate, and the answer, was yes, and that's one advantage of doing transperineal biopsies as mentioned. Absolutely. Good thought. Thank you for your comment.
I do think this is anecdotal. I do think that when somebody's had their prostate sampled by one route and you have ongoing suspicion, it does kind of make sense to try the other approach. Yeah. Right. Do you want me to come up? Yes, please. Okay.
Let's do one more case.
Can I ask a quick question? Can you comment a little bit more about saturation biopsy on a small prostate? You got like 4 cores that were positive. You think you were oversampling based on the previous biopsy? Can you comment a little bit more about saturation biopsy and what scenario should we be thinking about it? Is it?
Yeah, I think good question. With MRI, really helping us to appropriately identify a lesion that you can target. I think the utility of saturation biopsy is pretty low. The reason why we did that here was, MRI shows no lesion in 2 instances, and the patient, has ongoing suspicions for cancer. He's already had a prior negative biopsy. We felt that to repeat the same thing is not going to be, high yield, which is why we did saturation biopsy. Now, how many cores should you do? I think is depending on the size of the prostate. And in general, my partners who do saturation biopsies will go like every 3 to 4 millimeters. And in this particular case, they mapped out 26 cores.
I know this is unfair to ask, but with the biopsy results in hand, when you go back at your MRI, is it truly negative, or was it potentially?
Great question. We actually did go back and looked at this with our radiologist. The second MRI was actually done at our institution, and there was no visibly identified lesion. Yeah, could have been masked by the prostatitis that they saw, but the prostatitis was mainly in the peripheral zone, not in the anterior part of the prostate. But good question.
It's a DC harder to read.
And I think that emphasizes the point that there are false negatives on MRI. I'll present a case quickly. I don't think this is not on the, is this on the audience response? I'm not sure. Okay. 58-year-old man in excellent health. Father had prostate cancer, non-lethal. He was treated. The patient has stable mild LUTs. His PSA bumped from 5.4, to 5.4, up from 2.8 previously. We rechecked it. Thank you, Dr. Agner. 5.5. Digital rectal exam, no nodules, about 30 grams, and no prior biopsy. Next step, I don't think we have the audience response system for this. Next step, observe with serial PSAs, antibiotic, additional biomarkers, MRI with a plan to do a biopsy, MRI with a plan to do a biopsy if positive and observe if negative, or biopsy without MRI prior. I think according to guideline, you would be okay to do either additional biomarkers, MRI with a plan to do a biopsy, additional biomarkers, MRI with a plan to do a biopsy, or biopsy without MRI prior. My preference is to do an MRI with a plan to do a biopsy in that setting. And again, just to demonstrate that on the algorithm, in the initial biopsy setting, MRI is considered optional. If it's negative, I'm having trouble reading. If it's negative, we're doing the systematic biopsy. Sorry, this setup is not conducive to progressive lenses. But in the initial, if it's negative, we're going to do the systematic biopsy, and if it's positive, we're going to do the target plus minus systematic. The MRI is the one that I showed you previously, where you can see it on all phases. It's a PIRADS 5 lesion on the left there. And are we going to do the target only, the systematic only, or the target plus systematic? Again, according to the guideline, it would be appropriate to do target only or target plus systematic. My preference is target plus systematic. I think Dr. Egenart and I could do arm wrestling match up here over that decision. But yes, you'd be okay to do target only also. And here's that on the algorithm in the initial biopsy setting, you do the target plus minus the systematic biopsies. So patient undergoes transperineal systematic plus target biopsy, and we found grade group 4 in the region of interest and grade group 3 also on the left in the template biopsy. So in this case, it did not help us to do that. And one thing to keep in mind is as you consider the number of cores positive, this is relevant for example, distinguishing between unfavorable intermediate and unfavorable intermediate, not like this case, but when you are counting cores, the entirety of the region of interest counts as one core. So that even though that says 3 out of 3 cores, that counts as 1 out of 1. And that's it. Thank you.
I have a question regarding the issue of adding systematic biopsy. When you already intend or perform a targeted biopsy, is there any data about extra infection rate? Because setting-wise, you're already set for the operation, and everybody's seen, at least in the beginning of the targeted biopsies and the fusion biopsies, that there are many cases that the targeted biopsy is negative and you get cancer elsewhere.
I don't know if you want to take that. I will say that doing the systematic, obviously, I don't think there's great data showing that it's increased risk of infection. It does increase cost because you're processing more biopsy specimens and the pathology costs are high. It does increase the risk of identifying low-grade cancer, which we don't want to really find. So there are definitely downsides, but your point is well taken that you're there anyway, and what is the downside risk of taking extra cores? I don't know if other people have more insight. I don't want to take up too much.
It's okay. Should we start? Yeah. Go ahead. Nick?
We have some patients that have renal insufficiency that need to get an MRI, and if they can't have gadolinium, is there an effect on the MRI, and what effect would that be?
So there are newer contrast agents now that can actually be MRI contrast agent that can be administered even in patients with poor creatinine clearance. I think the side effect or the complication that people worry about is nephrogenic systemic fibrosis, but with the newer contrast agents, it's actually safe to administer to get MRI with contrast.
I would also emphasize that the contrast enhanced component of the MRI is probably the least important.
Yeah.
So if the nephrologist or the radiologist is freaking out, you can omit it.
Yeah, and the PRIME trials show that biparametric is not inferior to multiparametric. We've actually, in our institution, not been using it since 2018 with the exception of failures and post-focal cases.
This question is for Dr. Watts, of course, in the panel. I believe there's some data that shows that cleaning the needle with formalin or some other disinfectant has decreased infection rates. And if that's true, then that would be pretty low-hanging fruit.
Yes, there's data from music, actually. So our infection rate at Michigan with transrectal biopsies before we completely switched to transperineal was like 0.3 to 0.6%, depending on the year. So in addition to doing, antibiotic prophylaxis, we disinfect with formalin and then saline in between every needle pass. But 0.6% compared to 0% risk is better. So if you do have the system to support transperineal biopsies, I think it makes sense to do so, and you have the expertise to do so. It makes sense. But if not, transrectal biopsies is okay, and that's why the guideline says you can do either. But that was before the updated data from the PREVENT trial.
Okay, and last question, I'm not aware of any data on alpha blockers. I think that also might be low-hanging fruit of patients urinating in maybe 30 days or short-term.
There is a slightly higher risk of some retention after TP biopsies than after transrectal, so you can certainly consider alpha blockers even for the peri-procedural period to mitigate that, yeah. So this is just sort of some looking ahead future directions. You've heard about the Stockholm 3 test earlier. A couple of our faculty mentioned this. So this is a blood-based test, but it's really an algorithm to predict the likelihood of grade group 2 or higher. So it's a combination of these plasma factors in addition to this polygenic risk, which is comprised of a number of SNPs, as well as patient clinical data. This was originally validated in Sweden, and it's in pretty widespread use there, but the US validation trial in a very different population was completed and published last year. Over 2,000 patients were enrolled, and you can see the tremendous diversity between the actual racial and ethnic groups that were included in this trial. And you can sort of see a map of the number of centers that participated. What was really interesting in this study, without getting into too many specifics about Stockholm 3, is that it showed an improved area under the curve for detection of grade group 2 or higher prostate cancer compared to PSA in every single group. And it also helped to reduce unnecessary biopsies pretty much across the board in these groups. And it is now available in the US. You can order this. It is available, and I think that we will begin to see more research coming out as people start to use this in the U.S. population. There's currently a RCT trial that is looking to use this in the primary care setting, comparing it to PSA in a massive scale setting. I just mentioned PRIME, but PRIME was a very large study looking at biparametric versus multiparametric MRI. So the key point here is that biparametric MRI is non-inferior to multiparametric MRI for the detection of grade group 2 or higher prostate cancer. There are a number of benefits to doing biparametric over multiparametric. The most obvious ones being you don't need a needle, you don't need contrast, it shaves off at least 10 minutes to the scan, you don't have any potential toxicity from the contrast, and you enhance access to patients by allowing the ability to do more scans. Optimum trial, this was just recently published. This is looking at micro ultrasounds. This is a 28 hertz ultrasound probe in comparison to image fusion biopsy for the detection of clinically significant prostate cancer. They had a single micro ultrasound arm, they had a micro ultrasound and MRI arm, and then they had an MRI with conventional ultrasound targeted biopsy arm. And the key point of this is that they found that micro ultrasound alone as your imaging test at the time of biopsy was non-inferior to MRI with targeted biopsy for the detection of clinically significant prostate cancer. So while this machine is not cheap, it is certainly something that is cheaper than a magnet for an MRI scanner. So this may be a substitution or something to augment locations where access to MRI or quality MRI readers is limited. I'm going to say briefly about artificial intelligence. This is just a very, very huge subject in and of itself, and the boom is in pathomics and radiomics. This is a study from last year, 634 men who underwent a radical prostatectomy, 135 of whom had extraprostatic extension, and they used the radiologist to review the MRI from prior to the radical prostatectomy, as well as an AI algorithm to look for the detection of extraprostatic extension afterwards. The AI algorithm was essentially a 10-minute exam. This had been previously clinically validated in a prospective trial, and it was found to improve accuracy for the compared to radiologists. It reduced the biopsy targets in the prostate by about 50%, and it did improve inter-observer, inter-radiologist agreement on detection of lesions within the prostate. So when you compare the AI augmented MRI for detection of clinically significant prostate cancer and just multiparametric MRI in the trial, you find that it essentially outperformed multiparametric MRI. It had a higher sensitivity, it had a clinically statistically significant higher specificity, it had a higher positive predictive value, a higher negative predictive value, and a higher AUC and accuracy. And this is an ongoing evaluation right now, and I will just say this is one of many, many, many AI platforms that are being investigated right now. AI in pathomics is another area that is ripe with development, because as much as imaging is susceptible to technique and human input, which is completely variable, so too is pathomics. It's dependent on the person doing the biopsy, the person who did the scan and read the scan, and then the person who's interpreting the slides. Many levels of variability there. And in any prostate biopsy interpretation, there's an inter-reader variability for about 30 to 53% for Gleason score grading. So most efforts in pathomics have been on diagnostics and grade classification. What I will just say is that there are a number actually of both FDA-approved and Google-accessible platforms that enable rapid identification of areas of positivity on a biopsy. So it is not meant to replace a pathologist, but meant to significantly decrease their time to read. And then I'm just going to put this in at the very end. This is a platform. I have no conflicts with this company, but it is an FDA approved. It's the only platform like this that incorporates both MRI imaging as well as tracked fusion biopsy cores to generate a heat map of the area of clinically significant tumor or prostate cancer within the prostate. So this was what the MRI looked like initially. This is what the radical prostatectomy tumor volume was. This is what the heat map was that was generated by the platform. Same thing with an anterior tumor. It has also been shown to improve the detection of ECE that is not detected on MRI, so that can help for surgical planning as well. This is FDA approved and reimbursed now. There are some ongoing future trials looking, as I mentioned, the Stockholm 3 biomarker versus PSA in the US, as well as a additional study looking at exactly biparametric MRI versus multiparametric MRI and cognitive and image fusion in the UK for prostate cancer detection. Thank you.
And I'd like to say thanks to all of our faculty. Very, very well done. Hopefully this has been informative and insightful for you. You've learned, a few things that you can take back to your own practice. And as Dr. Egner mentioned earlier, we would appreciate you providing us feedback when you get the survey from the AUA. Please, take some time to fill out the survey. Any suggestion on the format, the way we presented the course, and the case, discussions, any suggestions will be, highly appreciated. Thank you all for coming, and enjoy the rest of the meeting.